Welcome to our second Trauma Anesthesiology Society podcast. I again am Joshua Sabenfield. I'm Associate Professor of Anesthesiology at the University of Florida in Gainesville, as well as a member of the Trauma Anesthesia Society. First, I want to once again thank our partner Doc Matters for hosting our discussion. Thank you for providing us a platform for us to start a new way of distributing information on how we care for the traumatically injured. Second, I want to introduce my friend, Dr. Kevin Blaine, who is here to help me interview Dr. Monica Vavilala. Dr. Blaine is a trauma anesthesiologist and intensivist. He is currently an assistant professor at the Keck School of Medicine of the University of Southern California. He was with us for our last podcast. He has worked on several multi-center phase 3 clinical trials and was a transfusion and hemorrhage translational scientist at the NIH until 2017. His current research interests include acute traumatic coagulopathy and the next generation of coagulation tests. Our guest is Dr. Monica Vavilala, a trauma anesthesiologist and neuroanesthesiologist at Harborview Medical Center. She's a professor at the University of Washington, Seattle. Dr. Vavilala, I'm sure our listeners would like to know a little bit more about you and your research interests before we get started.
Sure. Thanks for having me today. As you mentioned, I'm at the University of Washington in Seattle, and it's quite sunny today, so we're all enjoying a wonderful summer. I trained first in pediatrics at the University of Texas Medical School at Houston. I then did my anesthesiology training at the University of Washington, and I've been on faculty here for the past 22 years, focusing on studying traumatic brain injury related topics such as cerebral blood flow and autoregulation, hemodynamics, the relationship between blood pressure management and outcomes, as well as more recently around implementation science methods that can be used to improve adherence to evidence-based guidelines. I serve on the National Brain Trauma Foundation guidelines for traumatic brain injury and have been funded by the National Institutes of Health to study TBI outcomes for over 15 years.
Monica, you had a very impressive career, although I'm really struck by your comment that it's sunny in Seattle. As a native Washingtonian myself, that seems so unusual, but then again, it is August that we're recording this, and I guess that's one of the 2 months out of the year that it's not raining there.
Correct.
I hope you've had a chance to go sailing on the lake.
I actually did, and it's quite lovely. It's hard to be in an office this month.
I understand. Hey, let's talk about what brings you here today, which is recently the United States Centers for Disease Control and Prevention awarded a $7.5 million grant in injury control research to investigate injury and violence. I was hoping that you could elaborate a little bit more about what's being researched and why this is such a concern.
So this is a really important award because the Centers for Disease Control awards 9 to 11, between 9 and 11 awards to centers across the United States as centers of excellence to reduce the injury burden from prevention to acute care and including into rehabilitation. We were one of the original 4 what they call injury control research centers linked to a level 1 trauma center in the country starting in 1987. And we are pleased to report that we are now again selected as one of the ICRCs effective August 1st. And we're the only research center like this on the West Coast. So the reason this is so recognized by the CDC as an important need is injuries are a big public health problem, leading cause of death for folks over the age of 1 year. Geriatric trauma is a big problem these days with our aging population. And so efforts are needed to decrease the morbidity and mortality associated with the injury burden across the lifespan. The projects that we will be working on as part of this particular award include examining how to get kids back to school after a traumatic brain injury. This is a randomized controlled trial. The second project is evaluating suicide prevention efforts and policies around that, and how state policy can decrease suicide rates. The third project will be examining falls prevention in skilled nursing facilities, and we're also going to be examining how to decrease opiate use disorder in the region post hospitalization for an injury. These are very public-facing projects. The CDC is very interested in community, and 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 so it's important to put this in light of the fact that the CDC award sits at the Harborview Injury Prevention and Research Center, which examines questions pertaining to acute care research. As well as anesthesiologists, we're trying to figure out how to save lives and take optimum care of acutely injured patients. And there are a number of projects ongoing here at the center that are related to acute care as well.
And it sounds like you've kind of answered my next question, kind of on a global level, but kind of on a patient level. Why is this so clinically challenging? Are there any effective treatments for these kinds of injuries?
So I think I think there have been a number of studies that have been done in the acute care period to improve trauma care outcomes. And we went through the factor 7 phase, and we think there's great benefit to using tranexamic acid, for example, for hemorrhage. And then there's the whole transfusion practice that has seen a resurgence of the use of whole blood, which we are now using at the hospital. And so I would say that the opportunities to conduct high quality studies in acute care, in the in acute injuries, is quite large. In traumatic brain injury, for example, there are ongoing federally funded studies looking at brain oxygenation. There are also uh, projects that are funded to study clinical decision support and program implementation that includes the perioperative period and examine outcomes based on that. So while the CDC grant is doing more public health type work, the Injury Center itself partners with the Level 1 Trauma Center to do a lot of acute care research.
I think that's absolutely fascinating. So I was wondering a little bit, your grants covering a lot of different aspects. It seems like you've got your fingers, your tendrils in a lot of different particular disease processes. I was wondering if you could talk for a little bit about the epidemiology of these various projects. How many people are involved, how much money is involved on the table. Why is the CDC looking at injury as a public health issue?
Because injury is a public health issue. It's the leading cause of death among adults, among people over 1 year of age. So if you look at the CDC causes of morbidity, of mortality, you'll see it's in the top 10. It always has been. And in fact, even globally, road traffic accidents, for example, are increasing in its cause for injuries. So it's not a surprise that the CDC it recognizes this. In fact, it's part of its mandate to try and reduce the injury burden. So we're very pleased that you know that they are actually making these awards. And under the rubric of injury control are all of these, as you said, very heterogeneous uh, processes. So suicide prevention, for example, or fall prevention, they're all sources of injuries. And so in Washington state in particular, suicides are a big problem, particularly among elderly white males. And I think, part of this is attributed to the social isolation. Part of this is attributed to lethal means access, and so it's a complicated subject. Mental health issues are increasingly recognized as a source for associated um, with let's say um, success in fatality from firearms, and so they're all at the intersection of dealing with the injury burden.
And so my next question might come off a little bit naive, but I mean, I work at a level one trauma center, and I'm guessing a lot of our listeners might also be interested. But this award was given to Injury Control Research Center. What makes Injury Control Research Center? I mean, how is that different than just a level one trauma center?
So a level one trauma center is a designation provided to hospitals that provide high quality trauma care. In the state of Washington, a level one trauma center has to have an injury control center. Now, the size and scope of it doesn't have to be as big as we are, but there's been a long history of having an injury center affiliated with the trauma center, and we've seen our mortality rates go down. You know, the value of having an injury control center affiliated with a trauma center is that we can work collectively to decrease the injury burden from prevention to acute care and all the way through rehabilitation and reintegration into society. So at our center, we are very interdisciplinary. I'm an anesthesiologist. We have 56 faculty here at the center, and they come from 33 departments and schools. So we really try to tackle the injury problem across the entire spectrum that of fields that actually have a, a role to play in preventing injuries or improving outcomes after injuries. So we have nursing faculty, social work faculty. As we know, injuries are disproportionately represented among the underserved population groups, the homeless, lower socioeconomic strata. So it's really important to look at the health equity component of it as well. We have we have a number of specialties involved here: surgery, pediatrics, intensive care, emergency medicine. We have engineers at the center who help us look at environmental causes of injuries. And for example, marijuana and driving, distracted driving, elderly driving. We recently supported passing a state bill to around the distracted driving bill, which is a cause for motor vehicle crashes and obviously contributing to the injury burden. So the difference between a level one trauma center and an injury control center is that we take kind of a public health approach and a comprehensive approach to keeping people from being injured. But if you are injured, trying to figure out how to improve your outcomes and back to your work or school.
That's absolutely fascinating. You know, as a one-time federal employee myself, I know that the federal government gives fairly, I wouldn't say narrow, but somewhat narrow program directives, mandates for the various programs they do. I wonder if you could elaborate a little bit more on the specific aims and objectives of the CDC's injury prevention program.
So so this is a really great question. Their mandate really is to try to provide support for centers to address the public health needs around injury in their region. So, of the 9 centers who have been awarded, the specific projects may vary. So, for example, if you're the University of Pennsylvania, the particular issues in your community, in your hospital, for your patients may be slightly different than those that are in Seattle. And so there's leeway around um, figuring some of that out. Although I will say that the the CDC did lay out some high priority areas, and that had to do with opiates, suicide, fall prevention, and concussion. And that's because the National Institutes of Health necessarily doesn't address these processes from a public health perspective. That's really the CDC's mandate. And also because these problems are big public health issues. So we very much view injury as a public health concern.
It sounds like it's, I mean, pretty inclusive. I mean, you mentioned opioids and suicides and such like that. Um, and so, I mean, they gave you those mandates, those priorities, but is there any other areas that the injury prevention program is hoping to kind of solve or look at the same time?
So I guess if your question is, does the Harborview Injury Prevention and Research Center do other work besides this CDC work? The answer is yes. We have people working on developing protocols for how do we how do you define hypotension in elderly trauma? How do we provide evidence-based care, adequate nutrition, prevention of delirium in elderly trauma patients? That's one big bucket of work. The other is on traumatic brain injury. How do we uh, identify shock in these patients? We're beginning to recognize that patients, even with isolated TBI, have cardiac dysfunction, just much akin to patients with subarachnoid hemorrhage, and yet this has been relatively recent in terms of people trying to figure out that in fact cardiac output is depressed, and we need to be thinking about tailored and appropriate vasoactive agents in these patients. So there's a lot of work being done here to understand optimal hemodynamic resuscitation and support in patients with TBI. And then we're evaluating our practices of putting blood on, our helicopters when we go out and pick up injured patients and bring them back. And so the work here really is, as you said, beyond, I would say, just the CDC projects, these public health issues. There's a lot of work also going on around acute care here.
So it's very unusual for an anesthesiologist to hold this kind of award. I wonder what prompted you to apply for it, and what do you think enabled your application to stand out and be so successful?
Mhm. So I joined the injury center here over a decade ago as a faculty member trying to develop a research career, and received tremendous mentoring from pediatricians, from psychiatrists, from surgeons, in terms of how to think about trauma prevention and trauma care and trauma outcomes. And as I developed my own personal research career in traumatic brain injury, I started to I held an administrative role here at the center as an associate director. And there was an opportunity for me to apply for the director position a number of years ago. And I applied recognizing that it was this kind of a position is typically held by surgeons, emergency medicine physicians, or pediatricians. That's the norm. But there's no real reason why anesthesiologists should not consider these kinds of opportunities, because we really do understand how to, the factors that affect trauma patients, how to take care of trauma patients, what they need to improve. And our touch points are across so many different specialties that I think the traditional view of an anesthesiologist in the operating room alone really doesn't need to be. And I think the community was, I'm sure at the beginning, maybe there was some questions around that, but has been really receptive to the notion that the director of an injury center doesn't really have to come from one particular specialty. In fact, there are PhDs who run injury centers as well. So I think it's really more about content expertise. So I've been the director of the center for 4 years before we decided to apply for the CDC grant. And applying for the CDC award is really kind of really important because it legitimizes the center as a national center of excellence, and something that's externally validated by a federal funding agency is really critical to the university. So I think applying for the CDC grant is something I had to do, something I wanted to do to restore that status to the institution. But in terms of being a director of an injury center as an anesthesiologist, I think it's been a great experience, and I think the community has been very, very welcoming. I would say it's probably been harder for anesthesiologists to understand why I would want to do this than it has been harder for other specialties to understand that.
And so, I mean, one of the formal aims of the Trauma Anesthesia Society is research, but I think informally we're also concerned about mentorship and professional development. And I was wondering, Dr. Vavilala, if you had a message for other younger clinicians, anesthesiologists, interested in taking leads within their hospitals and communities on violence-related illness and injury.
Absolutely. I run a training program here for high school students, for undergraduate students, for graduate students, and for junior faculty. It's a pipeline program around injury. And so um, we have all these groups engaged in research at different levels based on their stage in their education, trying to, solve injury related problems. And so I think that the mentorship is really important. I think those of you who are starting out your careers, who are interested in trauma research, should seek out, people and institutions where this kind of work is being conducted, because if you're part of a system that does it, it's a little bit easier to continue to do it. There's no reason why anesthesiologists should not be at the forefront of trauma research. And I think the mentorship that you seek can be within your department or it can be outside your department. There's no barrier to seeking extra departmental mentors. And when I was, growing up through the ranks, my mentors had one in anesthesiology and one in the Department of Pediatrics, and then I added to that list as I tried to, sort of develop my career. So I think thinking broadly is really probably the way to go in today's climate, particularly since we're so clinically busy that maybe one mentor is not able to provide all the mentorship that is really needed for a junior investigator.
And Dr. Blaine, I know you had another question.
I got one more question for you, which is that we have an international audience for this podcast. So we've so far talked a lot about this option here within the United States, and I wonder if there's a message that you could provide to trauma anesthesiologists outside the United States, to traumatologists in Europe and South America and Africa and Asia.
Sure. So I do some global injury work. I'm the PI on an RO1 where we're um, doing a randomized trial to improve traumatic brain injury outcomes in Argentina. I also do some work in India around pre-hospital care, and trying to understand what are the risk factors and the modifiable risk factors for outcomes after injury. Um, the the burden of injury is really global, and it's really disproportionately affects low middle income countries. And so I think it's really important for groups to come together to try to identify partnerships where people can pool resources and strategies to figure out how to address the big problems. And I think that um, it's great to have a forum where the injury problem can be discussed, and we have a lot to learn about how injury affects people by learning from folks not within the United States, because that's where most of the injuries are actually, the injury related mortality is actually occurring. I mean, most injured patients don't even make it to a hospital. The ambulance systems are poor, and there's no formal trauma system, so it's people often don't get standardized care. And I think the other issue is, this is not dissimilar to the United States. I think traumas may not be sexy. And so, if you're comparing it to super specialty cardiovascular or neurosurgical care, you know, I think people don't often pay attention to trauma research and trauma care and trauma programs as much. And that's unfortunate.
Well, it sounds like there's opportunities then for our colleagues outside the United States to really step up and take a leadership role within their own communities.
Well, I think that's all the questions me and Dr. Blaine had. Dr. Vavilala, did you have any further comments you want to make?
Yeah, if people are interested in learning more about the intersection or overlap between an injury control center and a trauma center, or is interested in trauma related research, I'd be happy to hear from you.
Well, this concludes our second podcast from the Trauma Anesthesiology Society. If anyone has any questions that would like to address it to our speakers, please send them in the comments below, and we'll forward them on to the presenters so that we can answer your questions. Thank you again, Drs. Vavilala and Dr. Blaine, for your time. It was a pleasure discussing this topic with you.
Thank you so much.
Thank you, Josh.